Okay, you can go.
So I was asked to speak about carotid endarterectomy before CABG. And I think it's important to realize that up to 28% of patients presenting for a carotid endarterectomy are going to have severe reconstructible coronary artery disease. When I was at Duke, Dick McCann would always tell me that his best stress test was to let the cardiac surgeons operate on his patient, and those that survived he got, and they would survive fine, and his data would look great. It's a good number to remember. He never used to comment to the cardiologists on that because they'd always refer him to patients, so he was always protecting his referral source. 22% of patients presenting for CABG will have significant and severe coronary artery disease. When you operate on the carotid, you need to keep in mind the guidelines that still are appropriate, and those are the American Heart Guidelines, modified slightly by the SVS and modified slightly by the European Society for Vascular Surgery in the last 2 years. But in general, you need to be able to maintain an asymptomatic patient needs to have perioperative stroke rate of under 3%, and a symptomatic patient under 6%. And you also need to remember when you're doing a carotid CABG is why are you there? If they're completely asymptomatic, then likely the reason for doing it is either the degree of stenosis within the coronary arteries or the degree of stenosis within the carotid. Ad lib use into both territories seems inappropriate unless you can justify it by the evidence. If it's a symptomatic cardiac patient, you deal with the symptomatic field first. Symptomatic carotid patient, a similar problem. And the combined patient usually necessitates a combined procedure. In general, if you read the literature, if you do the STS database, and your database person comes back and says, you just dropped a star because you didn't pay attention to your details, you'll find that there are 33 risk factors for stroke during CABG. Of those that's significant to the talk today is moderate to severe coronary artery stenosis or carotid artery stenosis. And in general, most of these people will have the diagnosis made by ultrasound. And therefore, the problem with that is how good is your lab? And are you confident that they can actually give you an accurate degree of stenosis? If that's the case, some people will operate on that. If it's not the case, they're going to end up needing a CTA or a coronary an arch angiogram during their coronary angiogram. The second area where it now becomes apparent is that a lot of people will do an arch during a coronary angiogram, and so the stenosis will be found at that stage. This is a little different than in the past, and so the amount of information hitting the cardiac surgeon at the time of his CABG is now increasing. But the data has not caught up with the data. The analysis of the data has not caught up with the data that's hitting him. The main reason to do a carotid endarterectomy around a CABG is the prevention of stroke. But stroke in CABG is multifactorial. 37% is going to be atherosclerotic disease, mainly from the arch. 10% is cardiogenic emboli. 6% only is related to carotid vascular disease. 8% is related to shock and other issues. And 37% is I don't know why and it happened. And that could be iatrogenic or idiopathic or both. The risk of stroke in Naylor's paper, which is in 1999, and there's nothing similar that's been published since then. If you're a cardiac or a vascular surgeon and you see someone with bilateral disease less than 50%, they have less than a 2% stroke rate. And it's highly likely that you should not be intervening on that patient. They have a 3% stroke rate with unilateral lesions between 50 to 99%. 5% if they have bilateral lesions between 50 and 99%. And 7 to 11 when they have a unilateral occlusion. And thus at least the last two would seem to be the appropriate areas where you may wish to intervene. It's important to note that in the European guidelines, simultaneous management of coronary and artery disease receives a grade C recommendation. That is, it's only based on expert committee opinions and not on decent randomized studies. In a meta-analysis that was mentioned earlier of 16 studies, there was really no difference between carotid endarterectomy and CABG and stage carotid endarterectomy and CABG. And when you look at the actual data where you do risk analysis, you can see that for each of the points, all of the studies actually do cross the 0 line. There is a tendency towards improved outcomes if you do a staged procedure for stroke. And similarly, if you wish the patient to survive for your follow-up, you'll get the same set. It trends that way, but it does not support it completely. So then the question is what is staged? Well, you heard a little bit about interval. That can be at 4 to 1 week to 1 hour. And then there's non-interval with wake-up. That can be with people who like to do local anesthetic at the time, or general anesthetic if your anesthesiologists are nervous. And it is before the chest is opened and before heparin is given. There are good candidates for carotid endarterectomy before CABG. They need to have appropriate carotid disease, as I've outlined before. They must have stable coronary artery disease. It is not sensible to be operating on someone with crescendo angina. And they must have good ventricular function. Those issues allow for a good outcome in the staged procedure. You can debate local versus general anesthesia, and that's a local phenomenon, as all politics are local. If people can't do a good local anesthetic, or they don't want to talk to the patient but need to surf the internet or read the newspaper, local anesthesia is not going to work. If, however, they are able to do that, local anesthesia will work. The same with general anesthesia. And then in some places, you need to be at least prepared to insert an intra-aortic balloon pump if that patient does become unstable. And that was mentioned before as with regard to carotid artery stenting. Now, there are some data sets out there where people have looked at all their data. This happens to come from one of the Texas hospitals. And in general, carotid endarterectomy pre-bypass in the same setting is about 11.5% combined death and stroke rate. If it's performed on bypass, it's 9.5%. If, however, you do it off pump, it's far better, it's 3.6%. So while we can worry a great deal about whether we should stage the carotid or whatever else, it may be that we need to look away and look at how we do the CABG. Because the whole idea of this situation is to prevent stroke. And thus, it may be if they can do a good off-pump CABG, that's probably better for the patient than trying to worry about when and where you should do your carotid. Stage carotids runs about 10.2%, and so based on the other data that I've shown you, it all seems to fit that it is not, there's not that much significant difference between the two. So in conclusion, stage versus combined on pump, there's probably no significant difference. Wake-up interval is important, particularly if you need to apportion the neurological issues. The double finger pointing occurs all the time. Who caused the stroke? Well, it was obviously the vascular surgeon because he did it first, or it's obviously the cardiac surgeon because he touched the arch of the aorta. And that's often been a pressure on people, and that's why wake-up interval occurs. Off-pump bypass trumps on-pump bypass for stroke, and therefore in the patient with moderate to insignificant carotid artery disease, this is the way to go. Staged carotid endarterectomy requires a stable patient. The fool operates on the unstable patient. And the bottom line is a stage CEA requires surgeon and center expertise and institutional ease with what they're doing.